Hi, this is Tom Oden, University of Iowa. I'm going to show you an interesting case we did recently. Our spectacular chief resident, Lori Provencher, did a great job with the rhexis, and here you can see the nucleus fractus. At the end of the nucleus fractus, though, we noticed some plaque material in the posterior capsule, and we decided to polish that with a dry zone. You can see it was a mistake here. This very fibrotic and fragile capsule broke, and some of the silicone oil came forward. This patient had a pars plana vitrectomy and silicone oil placement for a complex RD. And now we're in a bit of a pickle because we have to figure out what to do next. We don't want any more of the silicone oil to come forward, so we're going to grab the viscoelastic which we had on hand, which was a cohesive viscoelastic. We're going to try to reform the anterior chamber and tamponade the silicone oil. You can see as we remove the IA here, though, we have trouble. The chamber collapses and the oil comes forward. We quickly use some more cohesive viscoelastic, and then we ask for some dispersive viscoelastic, in this case some visco to help us to form the chamber. There again, some cohesive doesn't work, and so now we've got the dispersive and it's formed the chamber better. Now we're going to go in with this MA50 three-piece lens. It's a great choice because it has an acrylic optic. We don't want to use a silicon optic in this case because it'll opacify with the silicone oil present. We're going to slowly place this in. We're trying not to have any more of the oil come forward. What we're going to do is use a traditional optic capture where the two haptics are in the sulcus, but the optic is prolapsed posteriorly to the anterior capsule. In this case, we're lucky because we have a perfectly formed anterior capsulotomy thanks to Dr. Provencher, who did a beautiful job with that. Unfortunately, during the capture of the optic, you can see that some of the silicone oil came forward, which was unfortunate in this case. However, the lens was in a good position ultimately, which sealed off the posterior and the anterior chamber, and we were able to remove the oil without any future oil coming forward. There was one little tidbit of oil which was left, which we removed with a 23 gauge cortex extractor. The patient's done well so far. We decided to place some sealant in the wound because we had to make the wound a little bit bigger for the placement of this three-piece lens. This is Tom Oden, University of Iowa. Thank you very much.